My name is Mark Rosenzweig. I'm from West Bloomfield, Michigan. And I'm pleased to announce that I have my doctor, my oncologist, with us, who's from the Henry Ford Cancer Center
So,
in downtown
hold
Detroit.
on.
And Dr. Gadgeel and I have known each other since 2016. And he's helped me with two journeys through chemotherapy. And I've kind of talked to him in the past about the role of chemotherapy and how important it is for us to have another tool in our toolbox. And I kind of dragged him kicking and screaming, but the second time he's been an ALK-dialk talk, and I think he's been at two of our summits, and he's on our ALK advisory board, scientific board. He's also a member of the Judith Tam U of M ALK-positive lung cancer research initiative. He's a member of ASCO's educational committee. He's a member of the IASLC as information committee. And he's also won the award for National Cancer Institute in 2012. He's a very humble man, so I probably wouldn't say that to anyone. But I also want to say that we do have a healing arts calendar that you can check out on alkpositive.org. And we have great opportunity to communicate with other ALK patients. And I'm going to start off with some polling questions. So here we go. This will also help Dr. Gadgeel know who's in the audience. So the first one is, when were you diagnosed? Okay, Summer, go for it.
When were you diagnosed? 11% of you were diagnosed under a year. 16% of you were diagnosed 1 to 2 years ago. 17% of you 2 to 3 years ago. 19% of you were diagnosed 3 to 4 years. 13% 4 to 5 years. Put me in there. 13% of you were diagnosed 5 to 6 years ago, 5% 6 to 7, 2% 7 to 8. Nobody here in that 8 to 9 range, but 5% of you for 10 years or more. That's amazing. So cool.
Yeah. What is your current treatment?
Okay, what is your current treatment? We don't have anybody on crizotinib or sunitinib this round. 5% plus me on brigatinib, 47% of you on alectinib, 36% of you on lorlatinib, chemo with a TKI, 10% of you, straight chemo, only 3% of you. No one here on the gilteritinib trial. We have 2%. Plus Mark on the Nuvalent trial. Other clinical trials, no current treatment, no NA, no one. But thank you for giving us an idea of what you're all, where you all are in
Last question.
treatment story.
That's a two-part question. If you received chemotherapy, simple yes or no. When did you receive chemotherapy? So these are some of the answers to that question. Prior to ALK-positive diagnosis, it was added to my therapy protocol upon ALK diagnosis. Upon progression, it was added to my chemotherapy treatment. I mean, TKI treatment. I'm currently on chemo without a TKI.
Great question, Mark.
Okay.
Okay, have you received chemotherapy? It's about half and half. 52% of you have not, and 48% of you have. Okay, of the people that have received chemotherapy, 39% of you received it prior to your ALK diagnosis. 36, it was added to my therapy protocol upon my ALK positive diagnosis. 21% upon progression, it was added to my TKI therapy, or 4% of you, I'm currently on chemo without a TKI.
Okay, I'm going to stop the questions. I'm going to introduce Jeff Sturm. Jeff and I are good friends, and Jeff currently is going through chemotherapy. And Jeff, can you introduce yourself? And then we'll get Dr. Gadgeel to get rolling.
Hi, yes, indeed, I am Jeff Sturm, You may know me from the newsletter articles that I've written now and again, and various things on the Facebook site. I'm a member of the board of directors of ALK-positive. I'm also a member of 2 of the medical committees and very active with those. I sit in on the advisory board meetings that Dr. Gadgeel is privileges us with his presence, I might add. And I'm a 10.5-year ALK survivor on my 7th different treatment, and I am on pemetrexed and lorlatinib right now, and delighted to be there because it saved my life. With that, I'll pass it off to Shirish.
Thank you very much. First of all, thank you, Mr. Rosenzweig. I tried to call him Mark. This is my old training about
My
not calling
father's
him.
Mr. Rosenzweig, but go ahead.
Just my training that I was told never to call patient by their first name. But anyway, I just wanted to make a couple of disclosures, and these are not the traditional disclosures like conflict of interest, but more about initially, I had a little bit of a skepticism about this topic when Mr. Rosenzweig wanted me to talk about this, partly because of what I've sensed over the years, especially from when interacting with ALK and EGFR patients, is there is a sense that when a doctor brings up chemotherapy, that is, that's the sort of the last resort. And I therefore always I'm very cautious about talking about chemotherapy, and I was a little concerned how it will go over a virtual meeting. But eventually I felt that I do want to talk about chemotherapy, and I hope to sort of explain why I feel it has become necessary to discuss chemotherapy as one of the tools. I also want to mention my goal is not to convince you that, chemotherapy is essential or not in your particular treatment plan, but really want to discuss chemotherapy just as one of the tools that we use to manage this cancer. And then finally, I might be mentioning some thoughts as to what I prefer to choose. And please don't view this as that's the right way to do things or the wrong way to do things. So I can tell you, I'm going to mention certain things, and a patient with the same sort of clinical features, if I see tomorrow, I may not choose chemotherapy or I might choose a different type of chemotherapy. So please understand that this is sort of a broad overview, and my hope is that I can sort of delve into it a little bit more in the question answer session afterwards. Also, I tend to talk a lot. Please don't hesitate to interrupt me if you feel you want to have a question, but my hope is to sort of present maybe for 20-25 minutes and then have a question answer session. So hopefully I can advance my slides. Okay. So I wanted to start off with the crizotinib trials for 2 reasons. One is this was among the first trial in solid tumor oncology, definitely in lung cancer. There was some data about similar in EGFR, but one of the first trials to show that crizotinib was better than the previous standard of care treatment, both in the first line setting, which is the 1014 trial, which is on your left, and then the 2 curves on your right were from the 1007 trial that was in the second line setting. So patients had already received prior platinum-based chemotherapy and had progression, were found to have ALK-positive disease. And in both those settings, the TKI was better than chemotherapy. First of all, I want to tell you, as a lung cancer doctor who's been doing it for 25 years, it just cannot tell you what it means to me even today that I have a stage 4 lung cancer patient and I prescribe a pill, when for the first 10, 12 years of my career, and even now for many patients, we do keep outpatient chemotherapy. But another reason to present this data is I would like to focus on the bottom box of the right-hand side, which is talking about the 1007 trial. And there was an indication, and this was not the primary goal. So one needs to view this with some level of caution. You look at, there are three curves. You can see the blue curve is the crizotinib, which patients who were on crizotinib did the best. But then between docetaxel and pemetrexed, so either of those could be chosen by the treating physician if they didn't get randomized to crizotinib. And you can see the orangish curve where pemetrexed patients who received pemetrexed did somewhat better than docetaxel. And it was recognized that pemetrexed or Alimta has better activity in adenocarcinomas or non-squamous non-small cell lung cancer, but particularly in patients who are never smokers or light smokers. So there seems to be, and we don't know the exact reason. So there is clearly it didn't perform as well as crizotinib, but among chemotherapies, pemetrexed did perform better than docetaxel. Whenever I talk about crizotinib, I like to show this image. This really doesn't have specifically something to do with chemotherapy, but for me as a doctor, this was the experience I had managing this patient now 15 years ago that really showed the value of precision oncology, identifying a driver genetic alteration and treating it, treating the biological changes that are driving the tumor, in this case, ALK gene rearrangement. So this was a 52-year-old patient, Iraq war veteran rather. And when he presented, was in a wheelchair, 2 liters of oxygen. He had already gone through multiple different treatments as are listed in the bottom. Now, one doesn't have to be a radiologist to see how much cancer he had in both his lungs. And he was found to have ALK-positive disease. He was started on crizotinib. And you can see a scan 3 months later, but I can tell you within 2 weeks, his cancer, his symptoms improved. He actually went back to work. So it was quite dramatic change that we saw in patients with this targeted therapy, but we recognized the deficiencies of crizotinib. It provided benefit, but it provided benefit for a relatively short period of time. And one of the deficiencies was it did not work as well in the brain. And this is another patient of mine who had what is called leptomeningeal disease. She had been treated with chemotherapy on crizotinib and came to us because they couldn't even do radiation. She had already received radiation to the brain, and she came for the alectinib phase 1 trial. So this is a patient who enrolled on the alectinib phase 1 trial and within 6 weeks had almost complete resolution of these changes that were seen on her scan. By the way, does anybody see the mouse that I'm moving on the screen, or you?
Yes.
Oh, you
Yep.
can see it. Okay. So we were moving all this during time. We showed that a TKI is better than chemotherapy. And then we went to the next generation TKI, which provided better benefit. And really, these data were part of the reason why we started having both the doctors and the patient that, chemotherapy is generally used as a last resort. It is, something that what we are excited about are the TKIs, and we're not that excited about chemotherapy. This is, of course, then these data with alectinib led to the randomized phase 3 study. We all are familiar with the ALEX that showed superiority. And I will tell you at that time when the ALEX results came out, my sense was, well, we're going to see all these drugs perform about the same. There might be some variations. And of course, I was proven wrong by the CROWN trial that evaluated lorlatinib as first-line treatment compared to crizotinib and what was presented by Dr. Ben Solomon, and truly some of the most remarkable results in solid tumor oncology, where now we exceeded the median progression-free survival exceeded 5 years, and there were 60% that were progression-free. Now, what is very dramatic about lorlatinib is that this is data, by the way, in patients who did not have brain metastases at baseline. And as you can see in patients with crizotinib, at about 3 years, almost 50% of the patients go on to develop brain metastases. Whereas that rate in patients, again, these are patients who did not have brain metastases, and almost none of the patients on lorlatinib develop brain metastases. And that is a big factor in lorlatinib showing even superior efficacy, or the CROWN results being superior to what was seen with the alectinib in the ALEX trial. Now, you're doing across trial comparisons. We don't have data of direct head-to-head lorlatinib plus alectinib comparison, but the extrapolation has been that overall lorlatinib provides better control. But what is important to note, two things, and I'm going to come to this again, is that there are still a small percentage of patients who have a progression as rapidly as they may have on crizotinib. So there's a very small percentage of patients who don't derive any greater benefit with lorlatinib as compared to crizotinib. And 40% of the patients do have progression by 5 years on lorlatinib. So it's not everybody who has that benefit for more than 5 years. And I also want to mention that there are 8% of the patients who on crizotinib were progression-free at 5 years. Now, we think that all these 8% of the patients who started on crizotinib would have done just the same if they had started on lorlatinib. But we don't know that for a fact. What I can tell you is that there is at least one patient who I started within the last 6 months, who within 3 months of starting on lorlatinib, newly diagnosed ALK-positive patient, had progression of disease, and she had MET amplification. And we added a MET inhibitor, but what is interesting to note is that crizotinib is both an ALK and a MET inhibitor. And so it comes to my mind, is it possible, and I don't have an answer to that, but is it possible that she actually may have done better if she had received crizotinib, because it's an ALK and MET inhibitor? So what is important to note is we've made tremendous advances with crizotinib, then with alectinib, and now with lorlatinib. It's important to note we don't have the same extent of benefit in every patient. And the reason we don't have the same extent of benefit is because eventually, in many, if not all patients, with any of the TKIs we use, we expect progression. And one of the mechanisms of progression is ALK mutations. And so what is interesting to note is that you see an increase in the incidence of ALK mutations as more potent the drug. So the incidence of ALK mutations was greater in patients who received ceritinib, alectinib, and brigatinib as compared to patients who received crizotinib. And we know crizotinib is not as potent an ALK inhibitor as these three drugs. And one of the important mutations, or one of the common mutations, was the G1202R mutation. It was with this focus that lorlatinib was one of the focus. So one was to have better CNS activity, but the other was to have G1202R activity, which alectinib, there's some debate about whether brigatinib has activity, but lorlatinib was specifically developed to address this mutation. So when lorlatinib was looked at in patients who had already received a drug like alectinib or brigatinib, it did show benefit. But what is important to note is that the benefit was not the same in all patients. If the patient had an ALK mutation, as the mechanism of resistance, the median progression-free survival was 11 months. If the patient did not have an ALK mutation as a resistance mechanism, it was 5.4 months, and that averaged out to 7 months. So, two important issues. Lorlatinib is a great drug after a drug like alectinib or brigatinib, but its efficacy differs based on what the mechanism of resistance is. If it's an ALK mutation, it's a better drug. If there is no ALK mutation, it may not work. It may still work, but not work as well. And the second point is, on average, the median PFS with lorlatinib is about 7 months. So, two more points about that. One is, I just showed you that the median PFS with lorlatinib as a first-line drug exceeds 60 months. But when you do it in the second line, by the way, this was not just second line, this was like getting third, fourth line. These patients had received chemotherapy. Many of them had received crizotinib, alectinib, sometimes even alectinib and brigatinib. So these patients were heavily treated. But when you use the same drug after the tumor has undergone or has been exposed to other treatments, the median PFS is far less. So the benefit we see with chemotherapy after ALK-TKIs may not seem as impressive, but part of the problem is with any of our treatments, when we are using it in the second, third, fourth, fifth line, those treatments don't work as well as compared to when you use them as the first treatment. Okay, so when anybody reviews the data for chemotherapy, you may not get that impressed, but you have to keep in mind that now we are using chemotherapy in the third, fourth line. And even with ALK-TKIs, they may not work as well in the third, fourth line as they work in the first line. So this is one of the reasons, because one thought that comes to mind is, well, because lorlatinib has some challenging side effects, could you give alectinib and then at progression use lorlatinib? First of all, we don't know when the progression is going to occur and what sort of progression is going to occur. Is it going to be MET amplification? Is it going to be an ALK mutation? And therefore, it is difficult to predict the ability to, if I may, rescue the patient with lorlatinib as second line. And that is part of the reason why, since the Crown 5-year update, we've moved to lorlatinib, though I still wonder whether there are some patients who would be better off getting some other drugs, but we don't have that data, and therefore we have moved. So I spoke a lot. I just wanted to mention two important points. One is that the median PFS with lorlatinib as second, third, fourth line drug is reasonably modest when you compare it to its activity as first-line drug. And secondly, the benefits with lorlatinib seem to differ when used as second, third-line drug based on what is the mechanism of resistance to the cancer, mechanism of resistance to the first-line TKI, be it alectinib or brigatinib. That is, if there is ALK mutation, the benefit is better. If there's no ALK mutation, it is not as good. What about resistance on second-line lorlatinib? So if patients got alectinib or brigatinib and then got lorlatinib, now being an even more potent drug, potentially even more potent drug, not only do you see ALK mutations, but you see compound mutations. That is, you may not have only one mutation, but you have a couple of different mutations, sometimes even 3 mutations in the same tumor. What is interesting is, even if lorlatinib may be active against each of these mutations individually, when you combine, both of them are present, lorlatinib may not be as effective. Compound mutations is something that we don't see as often. You could after alectinib or brigatinib, but if you use lorlatinib after alectinib or brigatinib, there's a possibility of seeing compound mutations. And it was for this reason that NVL-655 was developed. because it not only targets ALK mutations, but it targets ALK compound mutations. By the way, when I mean compound mutations, more than one mutation having emerged in a tumor that was treated with lorlatinib as second-line treatment. And as one can see, when a patient's cancer progressed on lorlatinib and the patient's tumor had a compound mutation, the response rate is quite good. Now, mind you, the numbers are very small, so it is early. But when you look at the response rate in patients who did not have an ALK-resistant mutation, the response rate is 22%. If the patient had single or compound ALK-resistant mutations, it was 52%. And it's interesting, again, the numbers are very small and we need a lot more data. And I don't want to suggest that if you don't have compound mutation, you shouldn't be considered for the NVL-655 trial, or once it gets approved, it shouldn't be considered. But just want to explain that we sometimes have this impression, okay, alectinib, then lorlatinib, and then NVL-655. But you do need to know that the benefits can differ based on what the profile of the cancer is after the patient's tumor has progressed. And it is not the same in every patient. What is also interesting to note is that the resistance patterns, and this is very early, we don't have a lot of data from the CROWN trial. You can see only 26 patients. So extremely early data, and as we get more data, this may change. But the early data suggests that the mechanism of resistance, if you use lorlatinib as the first drug, may not be similar to what is seen in patients whose cancer progresses if lorlatinib uses second or third drug. That is, you don't see any ALK mutations in patients who progress on lorlatinib as first-line treatment. Again, this is early data. It is possible that as we get more data with longer follow-up, we may start seeing ALK mutations. But at least based on what is available, there seems to be that not only the extent of benefit is different, whether you use lorlatinib first line or second or third line. Median PFS exceeds 5 years. If you use lorlatinib first line, it is only in the range of about 7 months if you use it, especially third, fourth line. But the mechanism of resistance may be different. If you use it second, third line, we tend to see ALK mutations and compound mutations, double mutations. Whereas if you use lorlatinib first line, you may not see ALK mutations. So if you have used lorlatinib and the patient has had cancer progression, like my patient had, that patient had MET amplification. And in this patient, this is a not different patient, not the patient I referenced. This is a patient who actually got started on alectinib and first, and then had progression actually in the brain, and then was on lorlatinib. And then in 2023 had progression of her disease. So this is not first line, this is second line lorlatinib. You can see the liver metastases that I'm pointing out. And then when we did a Garden test, a ctDNA test, we found that the patient's cancer had MET amplification. And that's why we started the patient in June of 2023 on lorlatinib and capmatinib, which is a MET inhibitor. This picture is from 2024, but I can tell you I just saw the patient, and the patient's cancer looks very good. So you can see how significantly the tumor decreased. 2 points why I'm showing this data. We shouldn't just assume that the next treatment should be NVL-655 or an NVL-655 trial. I think it is important to note why the patient's cancer has progressed. And in certain situations, it may be a MET inhibitor. In certain situations, it may be better to do chemotherapy instead of going to NVL-655. Again, I want to tell you this is all very early data, and it may emerge as we get more data that maybe the best decision is to NVL-655. But as of today, what we have learned is two things. One is benefits with TKIs or any drugs varies based on when you have used it, first line, second line, third line. Secondly, the mechanisms of resistance differ. In some patients, it's ALK mutations. Thirdly, the ALK mutations can be what we call double mutations or compound mutations if you use lorlatinib after second, third line. But you may not see that in patients where you use lorlatinib as first line. And NVL-655, as of today, has worked well, but as the efficacy benefits seem to be better if a patient has compound mutations. And one shouldn't assume that NVL-655 is the best option after lorlatinib. It would be better to understand what the mechanism of resistance is and then decide what the best option is. Now, I want to tell you this. I have enrolled patients on trial with NVL-655, irrespective of whether they had compound mutations or not. And we need more data. And as I said, it may become evident that maybe it doesn't matter whether they have compound mutations or not. NVL-655 is a better treatment. I'm just saying that the data suggest that the benefit may seem to be more pronounced in patients of compound mutations.
And Dr. Gadgeel,
Yeah.
if you mind me interrupting quickly.
No, please.
You're driving home the point that we're constantly making is that biopsy, biopsy, biopsy. It's not a linear progression. You need more information to make the best decision, right? And what would you recommend there, biopsies?
Completely agree. And something that I was going to come to somewhere in that context is absolutely biopsy. But I will tell you, there are occasions when a patient is quite symptomatic and you don't have the ability to get the biopsy done. And I have felt in those situations that instead of going to another ALK-TKI, maybe in that situation, I continue the ALK-TKI they are on and add chemotherapy. Because when the patient is relatively rapid, and that is the reason I'm not able to get a biopsy, like do it in a timely fashion, I need to make a decision, then I don't know what the mechanism of resistance is. And chemo is somewhat more blunt instrument that is going to impact in some ways, irrespective of what the mechanism of resistance is. And so in those situations, I actually have preferred to rely more on chemotherapy than going on to another ALK-TKI. Again, I have put on NVL-655, lorlatinib, but it really it's a consideration. That's all I want to say. So what are the points? And I want to briefly talk about the chemotherapy. So what is the sort of, this was all the setup. I then will be talking about chemotherapy. So these were the points I wanted to make. Post-alectinib tumors may have ALK mutations. Mechanism of resistance to lorlatinib in second and first line can be different. Lorlatinib following alectinib and NVL-655 following lorlatinib works better in patients who have ALK mutations. And so what is the right treatment after ALK-TKI in patients who don't have ALK mutations? And so I wanted to now briefly talk about what do we know about chemotherapy. So this is an old data. This is from 2013. This shows that the benefit with platinum pemetrexed is, if you used in the first line in ALK patients, is median progression-free survival of 8.5 months. Mind you, when crizotinib was approved in the initial trials, it was about 11 months, 10 to 11 months. So yes, it was better than platinum pemetrexed, but not that much better. And by the way, this is retrospective data, much more limited data. So it in the real world, it could be somewhat lower than that. But even if you look at platinum pemetrexed used in any line of therapy, first, second, third line, and I told you with any treatment, the benefits in the second, third, fourth line are somewhat less. overall as compared to if that same treatment was used in the first line. And so it still had a median PFS of 7.3 months. But what is interesting to note is that a focus on the right-hand curve is that there seems to be some preferential better benefit with pemetrexed or Alimta and platinum like carboplatin in ALK positive patients as compared to other lung cancer patients. We don't know the exact reasons. There are some speculations, but there does appear to be a better benefit in ALK patients and to some extent in EGFR patients also as compared to patients who don't have a driver mutation or have what is called as KRAS mutation positive lung cancer. So there's not only a preferential benefit with chemotherapy, particularly Alimta chemotherapy in ALK patients, but it does have activity that is, comparable or uh, not to, has something that we need to take into account if used as first line. I would never use chemotherapy in the first line, but I just want to say that it does have some striking activity. I also wanted to show that there is indication that in patients where chemotherapy was used after ALK-TKI, after the patient's cancer had progressed on ALK-TKI, if you continued that ALK-TKI and added chemotherapy, that they seem to do better than if you just did chemotherapy. Now, this is not randomized data, this is retrospective data, and there could be several reasons why the ALK-TKI was continued or the ALK-TKI was not continued. But there is an indication that continuing the ALK-TKI and adding chemotherapy, though this has not been ever formally studied in a clinical trial, those patients seem to do better. And we tend to, particularly in patients who had alectinib and then lorlatinib, I have tended to continue, if they progressed on lorlatinib, I've tended to continue lorlatinib and add chemotherapy. I just have not had enough lorlatinib patients that have progressed and I've added chemotherapy as yet. So what I would like to say is platinum pemetrexed appears to have superior activity in ALK-positive lung cancer patients compared to other lung cancers. Activity of treatment always is less in second and third line, and so a median progression-free survival of 5-6 months with chemotherapy may not seem impressive, but even with lorlatinib as second line, it is about 7 months. And for second and third line therapy, in my opinion, if the patient has progressed and you've done a biopsy, and if you still see the ALK gene rearrangement, but you don't see a resistant ALK mutation, I don't know that moving to another ALK-TKI necessarily is a better option than doing chemotherapy plus continuing the ALK inhibitor. We don't have randomized data, but we have enough data to say that it should at least be considered. And I will tell you that if a patient has more rapid progression, particularly if they've gone through alectinib and lorlatinib, and then they have rapid progression, and either I've done the biopsy and I don't find an ALK mutation, or I cannot do an ALK mutation because the patient's cancer is progressing rapidly. My preference, and big experts like Dr. Kamich or others may disagree, but my preference actually has been to put them on chemotherapy and continue the lorlatinib rather than enroll them on the NVL 655 trial. Now, 2 years ago, when we didn't have all this data, I used to routinely move them to the NVL 655 trial. Finally, we have to take into account two important things about chemotherapy. One is, of course, the side effects. And I want to say this, that there can be many different side effects with chemotherapy. But the two main side effects that the patients most complain about are fatigue and nausea. And I want to tell you there's a certain cumulative nature to the fatigue and nausea that you may see. Occasionally, you also see blood counts dropping, the white count, and the platelets. But fatigue and nausea are definitely something that the patients complain about. It is my experience that when we do chemotherapy in ALK and EGFR patients, they seem to have a harder time than when we use chemotherapy in other lung cancer patients where chemotherapy is the first line treatment. So there's something about having already been treated for 2, 3, 4 years and then doing chemotherapy and how a patient tolerates that as compared to newly diagnosed lung cancer patients starting off on chemotherapy and immunotherapy or chemotherapy alone. Um, the symptoms are more. I want to be upfront about that. However, the symptoms can be managed. So in certain patients, I will only start Alimta for the first round, where I have some concerns. How are they going to handle chemotherapy? See how they do. And with the second round, add carboplatin. Also, we generally want to do carboplatin Alimta for 4 rounds. What I do sometimes is after 2 rounds, stop the carboplatin. Some patients are unable to tolerate it. I know what Mr. Rosenzweig is going to say because he got started on Alimta alone and he ran into issues. But in general, what we try to do is tailor the chemotherapy to the patient. Finally, what we do is we do two chemotherapy drugs, carboplatin and pemetrexed. As I said, in most cases, not all, continue the lorlatinib. At that point, we do try to do 4 rounds. It's given every 3 weeks. It's all outpatient, but yes, it is a IV infusion. So it's not like pill taking at home and coming and seeing the doctor every 3 months or whatever frequency. Unfortunately, you do have to come every 3 weeks for treatment. So we do it every 3 weeks. After 4 treatments, we drop the carboplatin and continue the Alimta and continue the ALK-TKI if the patient is continuing on ALK-TKI. But at that time, we do try to make some changes based on how the patient is doing, try to tailor the treatment. I sometimes go to every 4 weeks. I sometimes reduce the dose of Alimta. And if the patient is doing well, I look at giving a holiday from the Alimta and just continuing the lorlatinib and give them some sort of break and then bring back the Alimta if they have recovered. So yes, there are side effects, and yes, you have to come much more frequently than just taking a pill, but it can be managed. In most patients, there are some patients who just can't tolerate it, and yes, in those patients, we have to stop chemotherapy. I also want to tell you that in some patients, we do only chemotherapy and stop the ALK-TKI. In some of those patients, that period of time, because patients have been on ALK-TKI for 2, 4, 5 years, then you do chemotherapy all by itself. And in some patients, after a break from ALK-TKI for 6 to 9 months, and there's no good data that I can cite, but there can be resensitization to the ALK-TKI. And so chemotherapy not only can serve a purpose of stabilizing the tumor, controlling the tumor when it is becoming challenging to control it with ALK-TKI, but potentially after giving some time off with the ALK-TKI, it may potentially resensitize to the ALK-TKI where you can come back with the lorlatinib or a NVL-655. So please understand that it's a tool. It has its challenges, but it is a tool that, at least in some patients, can really control the cancer for a very long period of time. And I sort of made these points before about lorlatinib is a great drug, ALK-TKIs are great drugs, but not everybody benefits to the same extent. And we still don't know what is the right TKI for the right patient as first line treatment. Though my default has become lorlatinib, I feel like that may not be true for all patients. The final thing I want to talk about is, as I mentioned, not everybody derives benefit even with a drug like lorlatinib. And so there is this concept emerging called drug-tolerant persister cells. And I want to make clear this is still a concept, and it is somewhat better defined in EGFR and KRAS lung cancers, and maybe not as yet as well defined in ALK. And what does that really mean? When you treat a patient with an ALK-TKI, particularly newly diagnosed, the drug we think kills off a lot of cells, but there remain a small proportion of cells that may not have an ALK mutation or a MET amplification, but have certain biological features that allows it to resist ALK-TKI. And we call them the drug-tolerant persister cells. That is, they are able to tolerate, not necessarily resist in that they have this mutation and the drug has, but they are just able to resist the effect of the drug despite being ALK-positive lung cancers and the patient being treated with ALK-TKI. There could be a variety of factors that could be the basis for these cells. And we believe these cells persist and form the nidus from which resistance emerges. We think that these drug-tolerant persister cells may be more likely in tumors that have p53 co-mutation, maybe more likely in variant 3 than variant 1. Again, pure speculation on my part. I'm just trying to tell you that it's not just the ALK that is driving the tumor, it is the main driver. But there are other features of the tumor, biological features that we are beginning to understand, such as p53 co-mutation, such as variant, that may determine what proportion of cancer cells will be drug-tolerant persister cells. And again, it's a concept that is not yet well developed in ALK. We are sort of trying to understand this. And when you have more than one of these features, if you have a variant 3 and a p53 mutation, the ALK-TKIs may not work as well, possibly because there is a greater likelihood and maybe a greater proportion of drug-tolerant persister cells remaining after the initial activity of the ALK-TKI. And so in many lung cancers, particularly EGFR, there is this concept of intensification of therapy based on variety of factors. If the patient has brain metastases, if the patient has a lot of metastases at the time of diagnosis, multiple bone mets, multiple liver mets, certain biological features such as co-mutations in p53, there's another gene called CDKN2. And also, there appears to be that if a patient is diagnosed with stage 4 ALK-positive lung cancer or EGFR lung cancer, and if we can detect that mutation in the blood, in circulating tumor DNA, those patients seem to do worse than if the ctDNA was not detected. So we know now that there are these features where these are not the patients who are likely to have progression-free survival for 60 months or more with lorlatinib or with a drug like osimertinib in EGFR lung cancer. And these patients, again, by the way, I want to be very clear. This doesn't mean a patient with p53 co-mutation is not going to have a median progression-free survival exceeding 5 years with lorlatinib. I'm just saying the odds of not having reduce as opposed to compared to a patient who doesn't have co-mutation of p53. So what is emerging from this concept of drug-tolerant persister cells is that should we just be looking at ALK-TKI as first-line treatment? So I told about chemotherapy when the patient has developed resistance. But what we are now trying to understand is how can we be much more effective? Should we be satisfied? No, not at all. Median PFS exceeds 5 years with lorlatinib. No, we shouldn't be satisfied. I hope it is 100 years, right? Median PFS. So at least in EGFR, they are looking at intensification of treatment. One of the ways, there are other ways, is by adding chemotherapy up front. So even in EGFR lung cancer, what was done was we would treat with a drug like osimertinib, it's their lorlatinib, and once the patient progressed, invariably we also did mutation analysis and that would determine, but most patients required chemotherapy afterwards. So thought was, well, instead of waiting to start chemotherapy, could you do it upfront? Now mind you, the median PFS with osimertinib is far lower. It is only 17 months. Even with alectinib, it is exceeding 30 months, and with lorlatinib exceeding 60 months. So it's a different disease. The benefit with upfront TKI is not as pronounced overall as it is with alectinib or lorlatinib. So the need for intensification is probably greater. But what was seen was, yes, if you gave chemotherapy and osimertinib, you had better progression-free survival as compared to osimertinib. But what was interesting is that in patients with CNS metastases, the benefit was even better than what was seen in patients who did not have CNS metastases at baseline. Now, mind you, osimertinib is a very good drug as far as CNS metastases. It traverses the blood-brain barrier. And we always thought of, oh, chemotherapy doesn't work in patients with brain metastases. But what was interesting is that adding chemotherapy to osimertinib actually provided better benefit in patients who had baseline CNS metastases compared to patients who did not have CNS metastases. Now, I am not suggesting that ALK patients who have CNS metastases should be getting chemotherapy frontline. What I'm just saying is that potentially, as we get more data, not now, but as we get more data, it could be in 3 years, 5 years, 7 years, I don't know, that we could be looking at intensification of treatment in some patients. And one of the ways that we could be looking at intensification of treatment is by adding chemotherapy to TKI. And in fact, there is a study called the Bright Star 2 trial that is taking patients who have stage 4 disease and randomizing them to brigatinib plus chemotherapy, or brigatinib alone, or brigatinib plus local treatment such as radiotherapy or surgery. And so even today, what we try to do is we start with the ALK-TKI. And if they have what is called as oligometastatic disease, limited stage 4 disease, I know it seems oxymoronic to say limited and stage 4, but there's some patients who have limited stage 4 disease. What we do is after the initial 3-4 months, when we've shrunk the tumor as possible, whatever the visible disease is, we may do radiation and even uncommonly surgery to kind of maximize the treatment against the cancer. And so what I just want to say is it's a concept that is still evolving, but I do want to say that chemotherapy may play a role in that intensification of treatment. And the final slide, I think this is my final slide, is that you may have heard of antibody drug conjugates. You may have heard of a drug called datopotamab deruxtecan, other ADCs. This is the telisotuzumab vedotin ADC. There are a lot of antibody drug conjugates, and some of them are being evaluated in ALK-positive lung cancer. Very simply put, antibody drug conjugates is chemotherapy. And as some of you may know, it has an antibody against a substance that is present almost exclusively on the cancer surface of the cancer cells. And the antibody binds to that substance. What the antibody is carrying with it is chemotherapy. These red sort of tags that you see are a chemotherapy that are linked to the antibody. And what happens is when the antibody is tagged on to the chemotherapy is tagged onto the antibody, the chemotherapy can't work. But once it attaches to the substance that the antibody is designed to attach to on the surface of the cancer, it gets internalized. The example I give is a tow truck with a car that is carrying it along with a tow chain. And so the car can't work until it reaches the garage, and the tow truck can only go into a specific garage. Once it is in the garage, the tow chain is removed. Now the car can work, and it just starts working and destroys the garage that it is in. I hope that made some sense. But what I'm trying to tell you is that what we are trying to do is, even with these new drugs, essentially it is, if I may, smart chemotherapy. So, what I wanted to convey today is that platinum pemetrexate appears to have superior activity in ALK-positive lung cancers compared to other lung cancers. For second and third line therapies, patients without ALK mutations should be considered. I'm not suggesting that should always be the preferred choice, but should be considered for chemotherapy and continuation of ALK inhibitor. And definitely we need to consider other options such as Novalent trial. There are toxicities with chemotherapy, but in many patients that can be managed. And there is this concept of should we very selectively. So one of the things I want to say is one of my hesitations about Bryce's R2 trial, a wonderful trial to do, but I'm just a little reluctant to do it in all stage 4 lung cancer patients. See, it was necessary in the EGFR population because the median PFS was only 17 months. If now you have some patients deriving benefit for more than 5 years, I just feel that it would be better to understand who are the patients who need intensification of treatment and then enroll those patients, whether it is P53, whether it is CDKN2 variant 3, and sort of try to get a better understanding of who are the patients who are not going to have a good benefit and then look for intensification. I hope I'm not giving people seizures by changing the slide so frequently. But what I do want to say is that there is a possibility in the future that we may consider chemotherapy as a part of a treatment plan of doing intensification of treatment. Sorry, I hope I made some sense and I hope I didn't talk too long. Oh my God, I've talked so long. Sorry.
It's okay.
I
I'm gonna wrap up real quick for a second.
I can
The
stay
art of
on
science.
if we want to stay on.
Okay.
So
The
And it
art
was
of
so
science of
great.
being a doctor, right? Each patient is different, but you have a lot of experience with ALK patients over the years. A lot of people don't have access to ALK experts. Briefly with the chemotherapy and everything, when you say the word chemo to your patients, what's the first reaction they have typically?
yeah, the first reaction is the more so in ALK-EGFR patients is we are going to something that is horrible, that is, not going to be as effective, and I'm just going to be sick all the time, laying in bed, and won't be able to. One of the great advantages of the ALK TKIs is most patients, not all, most patients are able to live their life, do what they have been doing, and they feel that that may not be possible. I can tell you one patient. My one of my patients was on Alimta and lorlatinib for 4 years, and I want to also tell you this. He's not with us anymore, but he would visit Greece. Sorry, that might indicate to some folks who he is, but and I apologize for that. But he would visit Greece every summer. So what I want to tell you is that despite being on chemotherapy for 4 years, and I'm not saying that's every patient, but he was able to do almost everything he wanted, including what is very, very important for him is travel in the summer to Greece. So um, again, I want to be very clear. It's not every patient. But then I've had some patients who have had problems with lorlatinib, alectinib. So it's important to realize that it's not the end of the road. It's not that you're only going to be just laying in bed and with a, basin next to you because you're throwing up. And we have a lot of good ways of managing toxicity. Yes, it means you're going to the doctor's office a lot more frequently. And yes, there are going to be days where you're not going to feel great. So I don't want to sort of sugarcoat that. Anyway.
I'm going to bring Jeff into the conversation. Jeff, can you give a little bit of background of your MVL experience and where you are today? Jeff still with us? All
Yeah, I'm here. Hang
right,
on.
go for it.
Somebody snuck in there and hit my mute button for me. So I progressed. So I was on crizotinib originally for 9 months. Then I was on alectinib for 6.5 years. And then I was on lorlatinib for 3.5 years and progressed on lorlatinib with double mutations in my abdomen. So it was abdominal cancer, the abdominal wall, and painful, just kind of awful. And by the time I crawled into I was literally the second patient on the lorlatinib trial, on the NVL-655 trial on March 1 of 2024. I was really in bad shape. And within, I'd say, 45 days, I was much, much better. It worked really fast. Only problem was that at about the end of the second month, my liver enzymes went through the roof. So I had to do a hold. Then we went back on, and I felt great again. And then we had to do another hold for the liver enzyme. So it was one hold after another, unfortunately. And by the time we got to September, I was well. I felt great, even with multiple 3-week holds. But they had to take me off the trial because even at the lowest dose of 50 milligrams, it didn't work. I had told them originally I'm super sensitive to these drugs. If we'd started at 50 milligrams, I think my liver probably would have taken it if we titrated up. I've had that experience with the other drugs. And I'm hoping that once it's approved, that I can actually do that because I do have double mutations that I know about. You want to say something, Shirish?
No, I completely agree with you. I think that there might be a possibility. The other thing I wondered, though they did not, they looked at a lot of factors. I don't know all the data, but supposedly the company, and there's some wonderful, wonderful people in the Novalent team, very smart people. They looked at a lot of factors. I have wondered whether it has to do something with the length of time you've been on ALK-TKIs before going on NVL-655. And I've wondered, pure speculation on my part, and Novalent folks might get mad at me, that actually if you had a break from an ALK-TKI and then went on Novalent, maybe you may not have those, whatever the small percentage of patients where liver enzymes went up. So just pure, again,
Yeah,
absolute speculation on my
yeah.
part.
I hope to find that out in
Yeah.
maybe less than a year. So in September of 2024, I started the doublet, carboplatin and pemetrexed, and I went back on lorlatinib. And that first 4 cycles hit me pretty hard, and I really didn't quite know how to handle it. They were loading me up with steroids like crazy, and I couldn't sleep for 3 days, So finally, I figured out how to manage the steroids, which was a very, very low dose for an extended 5 or 6 days that worked really well for me. And just this last cycle, first of all, I should say that by December, I showed no evidence of disease on any of my scans, whereas my abdomen was absolutely loaded with it. So I kind of hate it, but I love it. So I'm just delighted that I have it. And in the last couple of cycles, I've been able to manage it really well with exercise and very small diet. I don't get the nausea, thank God. I do get the fatigue, but I don't buy it. I refuse. I just get up and get moving as best I can. So I'm happy for it. But I will say that I see it not as an end in itself, but as a transitional phase. I happen to be on the Research Acceleration Committee of ALK-positive, so I get to see all of the research that flows through our system. I get to talk with and reach out to biotechs on a systematic basis. So I'm very well positioned to go to the next treatment once it appears. I have to say at this point, gilteritinib looks like a good option, except that we tested my pleural fluid recently, the pellet for my pleural fluid, and didn't look like gilteritinib would work. I just got that note from Angel. So I'm looking around for something else. Maybe one of these vaccines is going to come up. Who knows? Maybe it's another chemo. There are stronger chemos out there, Dr. Camage tells me. But for now, I'm 8 months into chemo. And if you note, I got much longer responses from all of the TKIs than most people get. And I think part of that is because I used targeted radiation a lot. So if something popped up, we killed it. We didn't wait. We didn't wait a week. I mean, we just shot it. So I've had 56 days of targeted radiation, but most of them are just 1 or 2 days cycles that I never felt at all. So I'm still
So you
here.
mentioned, sorry to break
Go
in,
ahead.
but Dr. Gadgeel did mention about the EGFR study. So no one wants to test in a trial chemotherapy, but Bright Star you mentioned. So do you think would you ever use chemo at the starting point with a TKI?
Not yet in ALK. I don't know that I'm ready to do that off trial as of now. What I will say is this. Recently, I had a patient who was on alectinib for a year and had progression of disease. And I decided that I was not just going to do lorlatinib, I was going to do lorlatinib and chemo in that patient. So that patient did not have, he just had ALK, did not have any ALK mutation. We couldn't find any resistance mechanism. And the patient had quite a bit of progression. And so, what was my routine in the past, where I would basically go from alectinib to lorlatinib? I think that if I really don't identify mutation, and he, for a couple of different reasons, couldn't enroll on the NVL 655 study, I've decided to start on chemotherapy. And that, Mr. Sturm, Jeff, you just mentioned some exceedingly important points. And if I could just highlight, maybe you should have had him talk instead of me, but I'm just
No,
going
go for it.
to mention a couple of important things. One of the reasons, yes, chemotherapy causes fatigue, but invariably we choose chemotherapy when the patient is quite symptomatic. Jeff, you mentioned you have you had a lot of disease in the abdomen, and so it's not just that chemotherapy causes fatigue. It does, but it is also because we tend to use chemotherapy when the patient is more symptomatic. So that's one thing. The second thing is, I don't use Decadron to the extent that is actually the standard. So the standard for Alimta is that you start 4 milligrams twice daily, the day before, the day off, and day after. And then, because you do carboplatin, which can cause nausea, you extend the Decadron for a couple of days after the carboplatin. I actually only do Decadron on the day of the infusion. And then for the first 4 rounds, when we are doing carboplatin, I do it the day after. I don't do Decadron. And in some patients, at least over time, I actually bring down the Decadron. So the Decadron makes you feel really good for the first couple of days. In fact, many patients, when you start chemotherapy, say, "Oh, I felt fantastic." But I feel that Decadron, after you stop it, it's almost like a crash. And so not only do you have the fatigue from the chemo, but there is fatigue from the crash. And so again, there's no randomized study to show the way I'm doing Decadron is necessarily better, but I do tend to do less Decadron than what is sort of the standard, actually the recommended standard. There were a couple of things, is that the first 4 rounds, as mentioned, can be tough when you're getting both chemos. In some patients, I will sort of back off of the carboplatin before the 4 rounds. Having said that, If I've started chemotherapy because they are symptomatic, I'm doing everything I can to do the 4 rounds of the combination and then to do the maintenance Alimta with the lorlatinib to try and get the cancer as good, well controlled as possible. So it's a lot of things what Jeff mentioned. Doing your best, it is hard, but doing your best to maintain your activity level, doing your best to maintain a certain muscle mass. So some patients lose weight, some patients gain weight because of the decadron. But it is more about maintaining your muscle mass as best as you can. If that means lifting 2 pounds, lift 2 pounds, but do what you can to maintain your activity level. Even if it is walking 5 steps every hour, it has relevance. That is the best way to overcome fatigue. Yes, there are things that we can do, pharmacologically, but truly it is maintaining good diet, exercise, and activity that is extremely crucial. One last thing I'm going to say is the decadron causes some people to not be able to sleep. And then you're fatigued and your activity level goes down, and that breaks up your sleep wake cycle. So, one of the ways, and then people use medications, and it never gives you the type of sleep that you really need. And so, part of the reason why it is important to maintain an activity level is, and that all adds to the fatigue from the chemotherapy. Yes, there's fatigue from the chemo, but many of these things add to it. So one of the ways to limit it is to try and do your best to maintain activity during day, try and limit your naps during the day so that you can sleep better during the night. Doesn't work in everybody, want to be honest, but trying to focus on that is relevant. Two questions that I quickly saw in the chat that if I may mention. One is, yes, there was a question of using MRD to time chemotherapy or to look at the duration of chemotherapy. Now, I want to tell you there's absolutely no data, but very, very recently, particularly in the EGFR patients, I've started looking at if they have a baseline ctDNA that is positive, I will track it. And after about 6 to 8 rounds of chemotherapy, first 4 with the combo and then 4 more with the Alimta alone, I will repeat the ctDNA. If it has become negative and the patient is really tired and just unable to tolerate Alimta, I will stop the Alimta, continue the osimertinib. Again, I've not yet done it in an ALK patient, and then restart it if I start seeing that the ctDNA is starting to reappear. Um, Really not done it in enough patients to know how well the strategy has worked, but I can see that as a possible approach, though we absolutely don't have any data. And the second thing is bevacizumab. Yes, in some patients we do use bevacizumab. The problem is we have no good data to say adding bevacizumab or Avastin to chemotherapy is necessarily better than doing chemotherapy plus TKI. I also feel now you're going from 3 to 4 drugs. Anytime you're adding a drug, there could be more toxicity. And so there's always a concern. Yes, ctDNA is found on liquid biopsy test. Sorry. Yeah. So I don't do it routinely. There are some folks in certain situations, such as brain metastases or certain effusions, may consider it. I just feel more comfortable with chemotherapy and TKI, but yeah, I can see why somebody might consider adding bevacizumab.
If I
Jeff,
can
you have
add
any
one thing
follow-ups?
about the Dexedron,
Yeah.
what I figured out with experimentation was that I only needed a very low dose the day of and the day after, like literally 2 milligrams in one pill. But that day 3 and 4, it would hit me like a freight train. And if I took another 2 milligrams At 3, 4, and 5, it almost completely leveled it out.
So yes, some sort of trial and error regarding Decadron is very important. I will say one other thing, and Mr. Rosenzweig is aware of this. There are some patients on chemotherapy, especially if we had chemotherapy for a long period of time, they develop this leg swelling. It is actually a sort of redness. It looks angry to the point in a couple of patients, we were admitted them to the hospital thinking it is cellulitis and gave them IV antibiotics. It's basically inflammation in the skin. I can't explain why it happens only in some patients and why it happens in that shin area or just lateral to it. It can look pretty angry. It can be in both legs, it can be in one leg. Um, and interestingly, at least in a couple of patients, a small dose of steroids appeared to prevent that or at least limit it. And there was a patient who would take a small dose of Decadron for almost 10 days after every chemo to limit it. So I do want to say, yes, steroids can be tailored to the patient. I'm just saying, in general, I tend to use a little bit less than what is recommended as a standard dose. Um, yeah, if you can't get a biopsy done, you should at least get a ctDNA or a liquid biopsy done to see if you have a mechanism of resistance. But generally, we really try to do a biopsy at presentation. Now, sometimes I'll tell you when it becomes challenging. Some patients have pleural effusion or pericardial effusion, and you get a fluid, and not always you can do the ctDNA on those samples. And there may not be another good area to biopsy, and it may not be detectable liquid biopsy. So, in those patients, you either go on NVL-655 or chemotherapy. So there are certain situations where getting a biopsy can be challenging. But if somebody has pleural or pericardial effusion, they're becoming quite symptomatic. I've wondered, again, I'm not saying, but I've wondered whether it may be better to do chemotherapy and continue the lorlatinib rather than go on NVL-655. But that's pure speculation on my part right now.
So you hit this on your slideshow, and that is that we go from TKI to TKI to TKI sometimes. And my belief is, and I'm no doctor, obviously, but that adding chemo to it helps maybe reduce that resistance. And MVL is not available at this point, so because they haven't opened up the expanded use for a couple more months, correct? So we had a question in our group chat on Facebook saying that she progressed off of alectinib and was wondering if she should add chemo to alectinib before going to lorlatinib or skipping lorlatinib until she hits NVL. So what would, any ideas what you would do maybe
So
as a
I will
doctor?
say that in general, after alectinib, in general, I've tried lorlatinib alone, unless the patient has significant progression, or some patients develop continued progression on lorlatinib. And the reason is there appears to be evidence that it is a more potent drug. Now, if I post-alectinib, if I did a biopsy, I did not find any mutation, and I was concerned about the extent of progression, yes, I would consider that patient for chemotherapy and alectinib. I want to be very honest. This thought of maybe in patients who don't have ALK mutations, instead of going from one ALK-TKI to another ALK-TKI, instead going to chemotherapy plus continuing the ALK-TKI, is something that I've only recently started doing, I would say over the last year and a half. And so in the past, what was routine was alectinib to lorlatinib. Post lorlatinib, I really think it would become even more important to decide. By then, the patient has had two ALK TKIs. If they don't have an ALK mutation, I really wonder, to the point I might even say I lean towards maybe the patient may be better off getting chemotherapy and continual lorlatinib, then going on a third ALK TKI like NVL-655. We don't have enough data, but just based on what we have, I feel that that may be a better approach. But that's where I look at how quickly the patient is progressing. If the patient is progressing more quickly, then yes, I would rely a little more on chemotherapy and continuing lorlatinib.
Yeah.
Anyway.
We're going to cut you off right now. So you can go
No,
on to 10 o'clock at night.
no, I don't
So
know that
I
I'm going
know
to go
you.
on 10 o'clock at that night. I might want to finish at 8:30. Sorry. And maybe you
Yeah.
guys are getting bored of listening to me, but
No, we'll never get bored of you.
Thank you, Shirish.
But thank you so much. And it's an interesting subject because there is no data with this. And that's the importance of having a great doctor is that you have the experience and it's a science. It's not, we don't know all the time, right? So,
yeah,
thank
no,
you
it
so
is,
much.
everybody's situation, I cannot tell you, first of all, what an amazing group this is. The amount of education that you folks are doing is truly amazing. I just want to say one thing. I do have a slight worry about the group. So patients go on, at least some patients in my experience, they go on the group, they see all these patients, and yes, you do need, I feel, I had not done any analysis. Obviously, patients, I suspect patients who are doing well or have done well are going to participate a lot more enthusiastically than the patients who may not be, may be more symptomatic, so they may not join the call. And so the impression that you may get is, well, why is my cancer not responding like somebody else's? Like, how come my cancer progressed within 9 months on alectinib? And this doctor is telling me the median progression-free survival is 3 years or on lorlatinib. Why did my cancer progress so quickly? Median progression is exceeding 5 years. Please understand, there is so much heterogeneity, not only among the tumors and among the patients. And I want to be honest, we doctors don't know all the different heterogeneity factors. So there are variabilities. And so please understand, not everybody is doing fantastically, which may sometimes, and that's not the intent of this group, but sometimes may, mistakenly be conveyed. So yes, a huge benefit, but one last thing, sorry, I just remembered. ALK is a disease that occurs in somewhat younger patients than, and so please understand that we do encounter patients where fertility may be a issue. And so uh, if a patient is going to get started on chemotherapy and they're intending to conceive, then it would be important to get consulted for fertility preservation and what can be done. And the second thing is, um, it's okay to have sex on chemotherapy. I've just been asked, you don't transfer chemotherapy, or the chemotherapy we are using doesn't mean that they have to use a different bathroom. Like, you're not shedding, you're not going to contaminate your, commode, or, so the other members in the family can still use the same restroom. You can have sex with your partner. So you're not going to transfer chemotherapy. And some people might find this odd, but that question has been asked, and I just thought I should mention that.
These were
On
all
that
such
note,
great points, though. Yeah, you covered so much, and I loved how you gave your different perspectives, saying this is how I might do it. Somebody else might do it different, because there are so many new perspectives. Using it as a consolidated therapy, or so. No, I think it was great that you shed light on so many different areas, and we appreciate that. So thank you. And get yourself a doctor, everyone, or a second opinion that doesn't look at you as start at point A and you end up at B, C, or D. And if you look at Mark and the different times that he used chemotherapy, it was to get him to the next step, to knock out the cancer, keep him in the game. Jeff now, same thing, whether it's to get on NVL once it's approved in a year, or whether it's to get him on some other trial as it comes out. It's about.
So Summer, if I may, and I hope
Please.
Mr. Rosenzweig doesn't mind me saying this, okay?
Mark, by the way. Go
Yeah. So his story started in 2013, right? I always confuse 2012 or 2013,
Yep.
but okay. And the problem before he went on lorlatinib in late 2016, early 2017, was that he had progression, but he would keep having brain recurrences in brain metastases. Okay. But chemotherapy and the different ALK-TKIs kept him going from 2013 to 2017. 2017 January, I believe, or 2016 December, he started on lorlatinib on a clinical trial. Okay. So that was more than 8 years ago. And he got lorlatinib for 7 years. And then since January or February of 2024, he's been on NVL-655. And for the first 4 years or so of his cancer, he kept having many times recurrence in the brain. For the last 8 years or more, yes, he had some progression, but he has never progressed in the brain on lorlatinib and NVL-655.
Oh, that's my wife.
And I don't think that I really believe that all the treatment, not just the chemo, but the TKIs he got him to the point where we could then enroll him on the lorlatinib trial. And then he went on the NVL-655 trial. He does have compound mutations. But I cannot tell you as an oncologist, what it means to have a patient who for the first 4 years kept having brain recurrence, and now for the last 8, even though the cancer has progressed, but for the last more than 8 years, he has never recurred in the brain. And I'm touching wood because I'm a guy who's very superstitious, but it's just remarkable. And so really it's a journey, and we need to use every tool in the toolbox to control it. So
Without Dr. Gadgeel, I wouldn't be here in 2025 because I was turned down for a brain surgery, and Dr. Gadgeel fought for me to have brain surgery in 2016. And you need a second opinion, and you need a doctor who's aggressive, a doctor who knows ALK patients. It's important, very much important. Jeff can concur with his treatments that you need a second opinion doctor. So thank you, Dr. Gadgeel. It's very late, but Summer, when's our next ALK-TALK?
thank you very much.
Thank you. And we will all unmute and thank you in a second too, because this has been fabulous. May 4th, so you have a couple weeks off, everybody. May 4th, we have Ken Culver coming with our medical committee updates, letting you know what is happening while you are sleeping in the ALK positive medical committees. And then 2 weeks after that, I believe it's the 18th, but I might be lying. I had it earlier. We are having 2 University of Pennsylvania pharmacists on, oncology pharmacists, to go over the role of your pharmacist and how they can help you maximize your experience with your treatment. So the role of the pharmacist will be then. So thank you all so much for joining us. Jeff, thanks for sharing your story. And Mark, always, I'll be calling you out. There's plenty going on in his brain for sure. If you would all like to unmute and say thank you, that would be fabulous. Have a great
Thank you.
Thank
Thank
you, Dr.
you.
Gadgeel.
Thank you.
Thank you.
Thank you
Okay.
so
Thank you.
much.
You.
Bye.
Bye.